All right, welcome everyone. Today we're diving into some really practical counseling points for pharmacists who are on the front lines helping patients manage Parkinson's disease. The goal here is simple, to give you some clear, actionable tips you can literally use in your next patient conversation.
Okay, here's the game plan. We'll kick things off with the clinical basics. Then we'll get into the nitty-gritty of motor symptom drugs, tackle those tricky non-motor symptoms, talk about long-term complications, and wrap up with a look at our holistic role as pharmacists.
All right, first things first, the clinical essentials. You got to have a solid foundation to build on if we want our counseling to really hit home.
So what are we really talking about with Parkinson's? Well, at its core, it's all about the slow, progressive loss of those crucial dopamine-producing cells in the brain. And it's that lack of dopamine that directly causes the classic motor symptoms we all know. The resting tremor, that frustrating slowness of movement, and rigidity. And this is so important to remember. What's our actual goal here? It's not just about throwing meds at symptoms. No, our goals are so much bigger. We're talking about really improving their day-to-day function and quality of life, being super vigilant about side effects, and honestly, just helping them maintain a positive outlook. That last one is huge.
Okay, let's get into the medications for motor symptoms. This is really our bread and butter, and how we communicate here can make all the difference for our patients.
So this table gives us a fantastic snapshot of the main players. You've got levodopa, which is, without a doubt, our heavy hitter, the most effective, but we've got to watch out for long-term issues. Then there are the dopamine agonists, not quite as powerful, and they come with some really unique and serious risks we'll talk about. And finally, the MAOB inhibitors, which are more of a supporting actor, used to help with wearing off.
So yeah, let's talk about levodopa. It is the gold standard for a reason. And this is a key message for us as pharmacists. We need to be really clear with patients and other providers that this stuff works. There's this old myth about saving it for later, but the evidence just doesn't support that. If a patient's motor symptoms are causing problems, there's absolutely no reason to hold back.
And here are some of those counseling pearls that can make a massive difference. When someone's just starting out, tell them to take it with a little food to help with nausea. Easy enough. But, and this is a big but for down the road, you have to explain that as the disease progresses, they'll need to separate it from high-protein meals. Why? Because the protein competes for absorption and the drug just won't work as well. Also, and this is crucial for managing expectations, let them know it's not an overnight fix. It can take weeks to really see the full effect.
Okay, let's switch gears and talk about dopamine agonists. You'll often see these used in younger patients, but man, they come with a totally different set of rules. We have to be way more cautious in our counseling here because the side effect profile is, well, it's pretty unique.
So we've got to go through the usual suspects. The orthostatic hypotension, feeling dizzy when you stand up, the nausea and GI upset, and the potential for psychiatric stuff like hallucinations. And we absolutely have to warn them about daytime sleepiness. Even sudden sleep attacks, which is obviously a huge deal if they're driving. But there's one particular side effect that we really need to focus on. Get ready for this number, up to 50%. That's 1 in 2 patients taking these drugs who might experience what we're about to talk about. Just let that sink in for a second. Half.
And here it is, impulse-controlled disorders. We're talking binge eating, compulsive shopping, hypersexuality, pathological gambling. This is not a maybe mention it counseling point. It is absolutely critical. We have to, without fail, bring this up with every single patient and their family before they start these meds. These behaviors can literally destroy lives, finances, relationships. It's our job to sound the alarm.
Okay, moving on. As the disease marches on, it's often the non-motor symptoms that become the real hidden burden for our patients. Seriously, sometimes these can be even more disabling than the tremors or the stiffness. And just look at how common these are. We're not talking about rare side effects. We've got depression in nearly a third of patients, psychosis in a quarter, and then all the autonomic dysfunction. That's stuff like constipation, urinary issues, and that dizziness we mentioned. These are central parts of Parkinson's, and we have to be asking about them.
So, what do we do when a patient develops psychosis? Well, the knee-jerk reaction might be to add an antipsychotic, right? But hold on. The first step is actually to deprescribe. We have to look at what they're already taking. And there's a very specific order to this. We start by pulling the least necessary drugs first, like anticholinergics, and work our way down this list. Notice what's last? Levodopa. That's our last resort because it's the most effective for their motor symptoms.
All right, let's talk about the long game. Because after years on levodopa, some complications are pretty much guaranteed to show up.
Our job is to explain what's happening so we can manage expectations and ease their anxiety.
This is a super common point of confusion. We need to help our patients tell the difference between wearing off and the on-off phenomena. Think of it like this. Wearing off is predictable. It's like a battery slowly running out of juice before it's time to recharge. But on-off is totally unpredictable. It's like a light switch being flicked on and off randomly. One minute they can move, the next they're frozen. Helping them find the right words for this is a game changer for their doctor's appointments.
And all of this really brings us to our final and maybe most important point. Our role is so much bigger than just what's on the prescription pad. We're a key player on the healthcare team.
This is where we can be incredibly proactive. We should be champions for non-drug therapies, talk about exercise, how important it is for strength and balance, mention things like dance or Tai Chi, which have real benefits. And most importantly, we can be the connector, the one who suggests they talk to a physical therapist, an OT, or a speech therapist. And don't forget to point them to great resources like Parkinson Canada. It's all about empowering the patient.
And this quote just nails it, doesn't it? It perfectly sums up our goal. It's not just about getting the meds right. It's about making sure the whole support system is working for the patient to maximize their quality of life. We can be that central hub for them.
So I'll leave you with this one question to think about. How are you going to weave non-motor symptom screening into your very next patient chat? Seriously, just asking about their mood or their sleep, making that a routine part of your practice can have a massive impact. It's a small change that can make a world of difference. Thanks so much for tuning in.